and those who are on the webcast. We have a distinguished panel with us this morning, and our topic is connecting health, nutrition, and food security, and kind of just looking at what's happening in Africa and how can we make progress. We are excited to have the Director General of the African Medical and Research Foundation. AMREF is one of the biggest health and development organization in Africa. She's been at AMREF just for the past 10 months, but she's had a very distinguished career. You have bios at the back of your agenda, so I won't deal on this a lot. But Dr. Teguest Guerma is an Ethiopian national. She's worked with the World Health Organization for the past 26 years. Extensive experience at the headquarters in Geneva, representing WHO in New York and in a couple of African countries. She has a background in medicine and a postgraduate degree in infectious diseases and bacteriology and virology. Tough names. Dr. Guerma is in town. She was visiting Canada, New York, and she decided to stop over in DC. And she's meeting up with the African diaspora and needed to meet up with the U.S. civil society, public and private institutional reps, and basically to share with them about her work and some of the challenges she sees from the field in achieving some of the MDG goals that we're working so hard to achieve in Africa. So she'll share that vision, she'll share some of the challenges and prospects for progress. And with us is Dr. Kathleen Kurz. She's works with DAI as a principal development specialist for nutrition, and she's going to help us connect health and nutrition and agriculture. Most of us work in agriculture, but we know very well that these sectors hardly work together, and there is a very clear intersect between them, because we need food, we need to grow food, but that food needs to be nutritious to build up our health, and you basically need to be able to see what the intersection is. She's worked with AED for many years, worked with ICRW, International Center for Research on Women. She has a PhD in human nutrition and taught at Cornell, where she went to school. Florence Rolle comes to us from FAO, United Nations Food and Agriculture Organizations. She's worked there for the last 13 years. She's an agronomist and environmentalist. She's worked on soil rehabilitation, water management. She's also worked in Ethiopia as donor coordinator of the programs there. So she'll share with us a little bit of the field perspectives from Ethiopia and some of the challenges she's witnessed in terms of achieving some of these goals, both in agriculture, in health, and in nutrition. So let us welcome our panel, and we'll start with Dr. Guerma.
Good morning.
Good morning. Good morning.
Thank you, Daniel, for the kind introduction. So today I will be speaking to you about some effective strategies for lasting change and towards MDGs, but also about the challenges, as he said. But before doing that, I would like to introduce a little bit AMREF, the organization for which I'm working since 10 months. And tell you what is it about. What makes AMREF different from other organizations? What is AMREF? AMREF is an African international organization. It tries to find African solution for African problems. We have 90% of our staff is African. AMREF was founded in 1957 by 3 surgeons who wanted to use the tool of that time, claims, to take health services to the remotest place in Africa. We have 6 offices in Ethiopia, Tanzania, Uganda, South Sudan, South Africa, and Kenya, and we're opening an office now in West Africa and Senegal to cover Francophone Africa. But we are working in over 30 countries without having an office in Senegal. We also have 12 offices around the world in Europe and in America, which are raising awareness and raising funds for our programs. So AMREF focuses on communities. We work with the poorest of the poor, the most vulnerable, those communities that are living in the remotest area. AMREF is there where no one is there. AMREF first is not a disaster management organization or a humanitarian organization. AMREF is taking care of a lasting change in health. AMREF is not for the quick wins. It's not for the symptom, really looking at the symptoms, but we go for the roots of the problem. So our vision is really about the lasting health change in Africa, because we believe that the power for a lasting transformation of Africa's health is within its communities. So what do? We really approach the communities, build trust, and try to give them skills and means for the communities to change their health themselves. We are the catalyzer. They rule, and we let them change their health by themselves. We focus on women because we feel women are the heart of the communities, and changing women will change the families and the communities. So in summary, AMREF is a powerful catalyst for lasting change from within communities in Africa, building their knowledge, skills, and means to maintain their good health and break the cycle of poor health and poverty. So this is what AMREF is. What do? We work in HIV, AIDS, TB, and malaria. We also work in maternal and child health and reproductive health, water and sanitation, clinical and surgical outreach. Our flying doctors provide outreach to the remotest area because they take surgeons and specialists to the remotest area and we provide services. We also work in laboratory support. We're very innovative, and what we do is in all these areas, we always try to model new interventions, do operational research, back it with evidence, and we go for policy change with evidence-based advocacy. And we have done that several times with several programs. For example, for the personal hygiene and sanitation program, we started in a very limited community. Then we saw that it works, and the government of Kenya has now integrated that into all the schools. It has expanded in Uganda, it has gone to Tanzania. So that's how we start small, we model it, and then scale up with advocacy. We also produce guidelines for the community health. We have a laboratory standard guidelines. We have nutrition guidelines. We have many books, and we have a bookshop in AMREF that is developed by AMREF staff. We have also an international training center where we train, you will see later, for many things, but we have 33 trainings available in short and long-term training. So how do we do this? We work at the community level. We work at the primary health care level. So the first thing we do is really to train community health workers that we identify among the communities, women, men, that are part of the communities. And because they are part of the community's members will listen better to them. So we train them, and they go and educate the women, educate the men, and change their behavior into a health-seeking behavior. So women who are pregnant, who don't think that they have to go to the hospital because pregnancy is not a disease, when the community health workers are telling them that they have to do it, 4 visits during their pregnancy, and it's important for their health, they will come. And that's the way we work. We consider the community health worker as the bridge, as a facilitators between the communities and the first level health services. But we also know that we have a shortage of health workers in Africa, and I will tell you later within the challenges. So we know we need 1 million health workers to be able to reach the MDG goals. But we feel that we need to train mid-level health workers. For example, we train clinical officers. You know, in Maridi in South Sudan, for example, we have trained 270 clinical officers who can do 70% of the work of a doctor, but their training takes half the time of the training of a doctor, and the cost is 1/5. So this training officer, the clinical officer, can do C-sections, can do almost 70% of what a doctor can do. Because their training is very adapted to Africa, they're not also patched and put up for greener pasture. So this is mid-level training. This is Tumea Maridi. And this is just to show you that we are also using, because if training a health worker using the traditional way will take a long time. To train health workers, you will need a class of 100 person per year, and it takes time. We don't have this time. So what we do is we use innovative technology like e-learning, m-learning, and we train. For example, in Kenya, we have upgraded 22,000 nurses from enrolled nursing to registered nurse. You know, registered nurse can do more. Okay. And then, what happens when they go to the first level facilities? Because the first level facilities are very weak, there is no equipment, there is no drug, there is nothing. So what we do, we also sometimes build a model clinic health facility, we equip this facility, and we hand over to the government for them to follow this model and scale up these health centers to all the places. But, you know, the MDGs are around the corner, and 2015 is not very far, so only few countries have reached the MDGs, and if we continue do business as usual, we'll not be able to reach the MDGs. But what is blocking us from getting there? What are the challenges? So as I told you earlier, the first thing is really shortage of health workers. I said that we still need 1 million health workers to be able to reach the MDGs. We don't have enough doctors, we don't have enough nurses, and when we train the doctors, they are attracted by greener pasture because we don't have the retention mechanism in our countries for them to be able to work in the rural areas. So we need to train, and we need to find innovative ways to train more health workers, and we need to do also task shifting. That's what I was talking about earlier, really delegating authorities from the doctors to the clinical officers, from the clinical officers to the nurses, and from the nurses to the community health workers, because there are simple tasks that we can define. I, as a physician, know that some of the tasks can be done by a nurse. You know, some prescription can be done by a nurse. Some other tasks can be done by a clinical officer. So we could do that. That's the only way to go with that. Weak health services and limited access. You know that in some villages, women have to walk for so many kilometers to get to the health service. So how can we get access to the those women who have to work, you know, miles and miles to get to the health services? How, and when they get there, how can we ensure that they're getting the services? Because most of the time, as I told you, there's no drug, there's no equipment, there's one person to do everything. So how can we do this? So this is what we're doing, really trying to strengthen the peripheral level. And the other thing, and I know my colleagues will be talking about a lot, nutrition and about food security and other things, but it's poverty. Women are poor. Sometimes we give them drugs, but they are empty stomach. How can they take the drugs if they haven't eaten? How can you give to a person who has an empty stomach a lot of drugs and then they will not be able to take it? And also because of poor nutrition of girls, the pelvic is contracted, and when they go for early marriage, they have obstructive and long labors, and we can have damage of the vagina and have fistula. And this is one of the consequences of really long and obstructive labor. And AMREF, you know, is operating, has operated from 92 to 2009, 20,000 fistula cases. And this shouldn't happen. This is something we shouldn't happen if we have a good services. And you know, for those women who have fistula, because they have some leakage of urine and stool, they are very isolated. They, you know, they don't even tell what they have, and it's a terrible situation. And operating this women, of course, when it's a stage up, it has already happened, but it shouldn't even happen. Gender issues and some negative cultural beliefs, you know, gender imbalance, gender violence, and also some negative cultural beliefs will not allow the women to go for health services. So how can we do that? And that's where the community health nurse workers are able to change this, because they involve male, they educate the women, and you know, in Afar, for example, in Ethiopia, because we have trained community health workers in one area, we have been able to distribute bed nets, we have been able to educate the communities, and the malaria prevalence have been reduced from 61% in 2005 to 41% in 2009. So there is some impact by using community health workers. Limited involvement and civil society and private sector. Civil society organizations in Africa have mushrooms, like, you know, everywhere because of HIV/AIDS, and sometimes they don't have the capacity. Sometimes it's a one-man show. Sometimes they just have a big car and a Land Cruiser and an office, but there's no capacity. We need really to strengthen the civil society capacity, but also we need to involve them in policy making, in decision making, and if this is not done, you know, they cannot be respected by government and others. We also need to have an African position. You know, the civil society needs to develop, need to really be very, very strong and discuss with each other and develop an African position for all issues, you know, health, agriculture, and everything. We need to know what is their position. The private sector. The private sector cannot continue to be completely isolated, profit, non-profit. That barrier between the private sector and the non-profit is now really getting less and less clear. We all need to work for the same objective. We need to involve the private sector. Let's, for example, talk about distribution. We in the public sector, we're trying to distribute bed nets to the communities, but we have no expertise in distribution. But on the other side, we have the private sector, let's say Coca-Cola, they know how to distribute things. Why can't we use the expertise of the private sector in distribution instead of reinventing the wheel ourselves? So this is the way we need to work in partnership with the private sector, but not really for a CSR, good visibility. Private sector does one-off of that's not the way to do it. But the most important thing from all, lack of national leadership and accountability. First, leadership. I think national government need to be sitting on the driving seat and lead. They need to know to have a national strategic plan. They need to know what they want. And when donors are coming to propose some fund to them, they should know which area they should be funding. Not just say, yes, we accept these funds because the donors would like to fund this area. So the leadership is very important. But also accountability. How are our leaders accountable to the people? Our leaders went to Abuja and committed that they will have 15% of their national budget for health. They came back and only 4 countries did it. So how are we making them accountable? We need to have activism developed in Africa. We need to ask them for this. And the wind is blowing on this direction now, so I'm sure things will change. So this is really what I'm talking about. But also limited donors coordination. We talked about the Paris Declaration, the Accra Call for Action, but still donors are not coordinated in the field. We need to report to 100 donors with different formats. We need to do a monitoring and evaluation. No harmonization. So this is also an area where we need to really hold donors accountable. And they are not for the time being. But also, short-termist project versus program. Most of the donors comes to you and say, this is what we want to do. We want a project, nothing else. No one wants to really fund systems. But if we continue to do that, we will not be able to move very, very far. And that's why it really has not been very effective in the past, because we're not really supporting what needs to be supported and the long-term support. This is what we need to do. Also, most of our health workers in the past 10, 15 years have been biased towards curative medicine and not preventive medicine. We have been all taught into a public health approach, but most of us now do curative. We want treatment for this. We want this. But we need to develop the primary health care approach, the public health approach that we have all learned about in the past, and then have a comprehensive approach to medicine. And I talked about but also too much, fragmentation. I'm working for the HIV/AIDS program. I don't care about TB. Although 50% of the cases, we have a co-infection between TB and HIV. And my project is this. One day I went to one project in Kenya, and it was a water and sanitation project. And then we finished visiting that, and then we went to another project just close by, and we talked about trachoma. And I said, why are we talking about trachoma now? We have water, and the children should wash their faces and have no more trachoma. So what we should be monitoring is the number of reduction in the trachoma cases, because we have now water there. But the person couldn't tell me this, because he only thinks about his project, about what he has. And then limited ownership and contribution for Africans. I think if we want to make a difference in Africa, Africans need to make a contribution to the health development and to other developments in Africa. Time has come for us Africans in Africa and in the diaspora to put something on the table if we really want to influence the agenda and set the agenda. But if we are only waiting for people in the US and in America and in Canada and in Europe to always raise funds for us, I think we will not be able to move forward. So it's time, and I hope that Daniel and others will take the leadership within the diaspora to mobilize more Africans to contribute to health development. AMREF is really willing to take the leadership in Africa, and we are leading it already. And lastly, it's really too frequent changes in global health agenda. Yesterday, it was HIV/AIDS. We talked about universal access. There was a commitment in Gleneagles. But where are we now? We have still 38% of the people who need treatment who are getting it. But we haven't achieved that. We went to maternal and child health. Okay, we're now doing maternal and child health, but I'm already hearing that we are going to non-communicable diseases in June. So you see, before we achieve something somewhere, we are already moving to something else. So how can we achieve something concrete and have an impact on health development if we do this? Finally, I would like to say AMREF is just one stakeholder in the health development. We feel that we need to work in partnership with all of you. We need the support from all of you to be able to make a difference in Africa. So that's why we would like you really to join us in tackling these challenges in Africa. And for us in AMREF, as the Director General of AMREF, I see AMREF really growing and really expanding in Africa and becoming one of the African non-governmental organizations which can take the leadership in Africa, and I will see the growth. But I cannot do it by myself. So I need your support to be able to do that. Thank you.
Thank you. Thank you, Mr. Teguest. I'm sure that sparked some questions, some comments. I will ask you to hold on to those, if you can write them down. We're going to have Kathleen talk about health, nutrition, and agriculture, and then Florence, and then we'll have a Q&A after that.
Thanks very much, everyone. I thought that for Daniel's suggestion and request that three of them, someone from agriculture and someone from health, and I'm kind of stuck in between, and that I would take advantage and tell you a little bit about how nutrition is a bit in both. It has been, so I'll tell you about nutrition and health, nutrition and agriculture, look for some connections. These are, mine is a more general. I'm not going to tell you about exactly how it works in the field, but just mine is a little bit more conceptual, so we can begin, as Daniel says, to connect the dots. In nutrition, we have had a priority on the youngest children. That used to be 0 to 5, and the more we looked at child's growth in particular, the more we said, you know, between 0 and 2 years is really where the kid either gets off to a good start, and then in most cases they don't. After 2 years, growth is our indicator, right? The weight for age, height for age. That after 2 years, whatever percentile on that growth chart that a child is, they tend to track. They should have to, but it tends to be that they track along that percentile. They grow, of course, but they tend to stay at the 5th percentile, at the 10th percentile, well below the median where they should be at the 50th percentile. So we focused a lot there. There's a little consternation with child survival because that's still 0 to 5, but we're saying it's 0 to 5, but for the nutrition and the growth, it's particularly 0 to 2. This is in the context of 1,000-day campaign to bring more attention, not the new flavor of the month, but to remind everybody it's one of the health topics we need to pay attention to get these kids on a better track, because they'll do better in school, they'll have less illness, their immune system will be stronger if we do some of this. So 1,000-day campaign and scaling up nutrition are some major advocacy efforts that are going on thanks to our advocacy partners who realized that that was really missing, that we were very technical group, very pilot study oriented, getting every little dose just right and forgetting to bring that into the health and the agriculture circles so that a wider variety of people saw these connections. 1,000 days is actually pregnancy through 2 years of life. That's where the 1,000 days comes from, and I would say that that we need to focus on the pregnancy part even better. so that the birth weight is better, the maternal health is better, but a lot of the focus has been on 0 to 2. This is what we know the most about. So what do we know? We know that from the health side, that most of us, even though there is in our field as well an emphasis on the curative, most of us actually in nutrition have focused on preventing. So don't let the kid fall off the growth curve, because we know that they won't get on. What is that prevention? Those prevention interventions look like breastfeeding promotion, especially through 2 years, but especially only breast milk as the food for the child in the first 6 months, exclusive breastfeeding. What should the child eat in addition to having the breast milk from 6 months on? Vitamins and minerals in general. The ones we tend to focus on because they have the biggest deficiency and effect, there's the most deficiency and the biggest ill effects are vitamin A deficiency, iron deficiency, and iodine, which I'll mention in a little bit. And the easiest way to give, all these things are in food, but that's the intervention that's been sort of the most efficient when there is a pretty bad deficiency are capsules to the young children and iron tablets to the pregnant women. I'd say the vitamin A capsules win hands down because vitamin A is stored in the liver, so you only have to do it a couple times a year, so either in health days or as part of regular clinic work. This is given in many countries. The other aspect of nutrition, which has always put it squarely in the health field, is that a child will not grow well no matter how perfectly you feed it if the child's really sick. They'll lose appetite and they'll lose weight. The major ones are diarrhea, respiratory infections, especially pneumonia, and malaria and other parasites, which are the focus for children in the community case management. Putting those three together, those are the biggest three for the youngest children. Also, there is an emphasis on preventing that. The WASH interventions come to preventing the diarrheal disease, and bed nets, of course, to prevent the malaria for children and mothers, and other interventions. But if they get these illnesses, we consider it part of a set of nutrition interventions to treat those and try to get them past that bout as quickly as possible. They will have low appetite and eat less, so that's part of their falling off the growth curve. If you have a shorter bout of illness and fewer illnesses, obviously that would happen less, and then also encouragement for feeding so that they can try to get back up on the growth curve. Also under care of the sick child and nutrition interventions is, and this has probably received the most attention, is the ready-to-use therapeutic foods in emergency situations to treat severe acute malnutrition. This has really been a huge boon for the treatment of severe acute malnutrition. You just have to take them to the clinic. Mother have to go there for a month. Now there's packets that store well, they target well, they help the child recover very well. This is the Plumpy Nut or the Nutriset. Unfortunately, it is a miracle. It is great. Unfortunately, I think it's almost become synonymous with this is the major nutrition intervention. And of course, forgetting about all the preventive as well. What do we know about nutrition and agriculture? I'm going to come to some of the many things that can affect nutrition from the agricultural field. We talk about agricultural productivity, and that means that if productivity goes up, we have more food available. It's available in the country if this works. We're always trading off, can the producers make a better income from it, and can the consumers also afford it? If we have more productivity, then it's usually a win-win situation. Other things needed, markets, roads, and other infrastructure, that takes the more raw food that we have and gets it distributed as far as possible. Within the country, we're still on availability of food. And food processing and value chain work is very important because there's huge post-harvest losses, and anytime you can store it or process it, and as good a way as possible, then we have more food available because we have less loss. So these are go to the element of food security, that is the availability of food in the country. The other thing that's very important, and Teguest started to mention that that these illnesses and malnutrition go along with poverty. So in the rural areas, the poor, who are those people? Are they the ones participating in the value chain? Usually not, unless the value chain really reaches down to the subsistence farmers, sometimes the small holders, but they're less likely the commercial farmers, the ones who are from families where there's malnutrition. And so a real emphasis on livelihoods to increase food access so that their families have enough to eat. A focus more at the household and on livelihoods is really worthwhile. And in the rural areas, those livelihoods usually have to do with agriculture. Although we say that and I think this has come out pretty clearly with all the food insecurity and the high food prices, we know, I think it's sort of brought to light that the smallholders and definitely the subsistence farmers are probably net consumers in addition to being producers. So they're on both sides of this. So where are some things in the middle? Because if we go through this set of interventions and this set of issues, they all have to do with food and people eating the food, but they're really in different realms. And so I think as the Feed the Future has brought the nutrition in the U.S. government funding, as Feed the Future has brought nutrition over there, and we're not quite sure, according to me, you need it in both the health and the agriculture, and we're not really quite sure what's going to happen under the Global Health Initiative. Nutrition it's mentioned as being important in both, but I haven't seen it so much in the Global Health Initiative. And but we see some health at the end of the set of the intermediate results under Feed the Future. So we definitely are going to need some connections here. So I'm going to just pull out things that people are doing that start to make those connections. Some we've been doing for a long time and some not so long. Complementary foods was on the nutrition and health list. It is the one about where we need to think about food. Thinking about food for the young, and in each of these categories I say where we are. So we're in the formulation phase. We've done a lot on breastfeeding, we've done a lot on diarrheal disease, we've done a lot for the young children, but we haven't really figured out how to get the right amount of food. Kids need very little food, in fact, if you think of quantity on a plate, but they need all these perfect things. So it's probably the most difficult time to figure out, nutrition. And I think the way that I see this part, so it's been the sort of among the young child feeding, it's been the last thing that we're really grappling with. We're grappling with it now, and I would say it's in the formulation phase, because I think there's just been this realization that we can talk only behavior change and make some recommendations about using local foods and mashing and mixing right. But many people think that if products can be made that are for the children, that can be purchased with the right formulation, that will get the right foods into children. Of course, the big question is, can those products? So there's a lot of interaction with the private sector. There's a lot of work on these formulations with the private sector, waiting for the right formulations. There's questions about fatty acids. We've forgotten those. Vitamins and minerals we've been concentrating on. So, but we need to do this, and the private sector probably needs to be involved with some guidance from ones doing the research. And then, of course, the affordability will be the biggest question, and probably that will come from volume of food. Other nutrition food connections for a very long time, we've had fortification. We've been working on fortification a lot of times in staples, but also in oil. Iodine comes in salt. Iodine's never been a medical intervention where you hand out, except for maybe iodine in oil where they can't get it into the salt yet, but it's more a sort of the fortification issue. iodine and iron in staples. Iron is once again the stubborn one because it changes the color of the food. It's just harder to get iron in as a fortificant compared to vitamin A. And of course, there's other things we fortify, but like I said, we focus on these three because in particular, because the biggest deficiencies are in those three nutrients. Another nutrition-food connection, there's been recently, maybe in the last 10 years, a lot of emphasis on biofortification with the Harvest Plus project across the CGI, the IAR, the International Ag Research Centers. So we have orange sweet potatoes, we have staples there where the nutrients are enhanced at the seed or vine level. So that's a lot of agricultural research, and now they've got some products that stand up in many soil types, etc., that they're rolling out. And then the one that I really think has not received very much attention, particularly from nutritionists who don't tend to talk about food as much as the medical interventions, but is coming out as an intermediate result, rightly so, under Feed the Future, is we need to diversify diets. We can talk about putting, a nutrient in a food, fortifying, biofortifying, but essentially I think we'll get to nutrition diets when people diversify, when they have a variety of foods, because the diversity of food equals a nutritious diet, and it tends to bring people into greater quantities. These are all important associations. So if we worked on fruits, vegetables, legumes, animal source foods, some egg, you don't need very much, but you do need some of the fats from animal source foods, especially on children, in addition to an emphasis on staples, then we'll get to dietary diversity. We know very little about how to promote it. You need dietary guidelines in a country. How much will it reduce malnutrition, or probably it will be on the prevention side. So if you have a deficiency, you probably need that vitamin A capsule. But instead of vitamin A capsules for your young life, what do you need to maintain? So I think we talk of diet in the maintenance phase of good nutrition, not trying to bring up from severe acute malnutrition. You do need a medicine at that point. Some other things just to keep in mind. There's quantity of food and there's quality of food. I think in the quantity quantity tends to be, do people have enough to eat? Do they have enough, is there enough per capita staple available across a country? That tends to go more in the food security, the access part of food security realm, and the quality is being more equated with nutrition. And I'm finding that the separation a little bit problematic, as if you can separate them and deal with one and then the other. I don't think that's the way to go. Both are needed and they are interrelated. So just a few suggestions, and this isn't trying to be exhaustive, but again, my job was to try to make some of the connections. So what do we need more of? One I forgot to put on here is continued advocacy. It's been quite the advantage. The advocacy that went with Feed the Future, that goes with Sun, 1,000 Days, it's sort of raising it to a level where people can understand, not down in the scientific, technical areas that nutritionists have tended to bury it so people couldn't understand it. Been very grateful for the strategies and that's come from the advocacy efforts, and I think those very much need to continue. Other things more on the programmatic side, I think there's been, I think we need the research to continue on the staples, but I think we need to also see research and ag extension on the fruits, the vegetables, the legumes, the animal source foods, and how to get it to the make sure that all people get that. A note about vegetables is that green leafy vegetables are very inexpensive, and they have tended to become, from qualitative research around the world, sometimes people don't eat it because it is so inexpensive. It becomes a low status food that gets fed to the animals, and people have, but they put greens in stew, so it varies from country to country, and I think somehow raising the status of it's very good for you to eat and for flavor, and to bring that status back up, it could be some emphasis from nutrition education. We need promotion of dietary diversity. I put the private in parentheses because I think they will do that as advertisers do, but I think some overall message about dietary diversity should probably come from the public health people and maybe a government campaign. As I mentioned before, I think we need an emphasis not just on the value chains and the amount of food coming out of the ground, the availability issues, but the access issues as well and the livelihoods, especially for the most poor. Remember that RUTF and the plumpy nut is not our only nutrition tool that we need to prevent. And I think I've already mentioned we need public-private partnerships for affordable, emphasis on affordable complementary foods. Continue emphasis on subsistence and smallholder. There's a lot of emphasis there now, I think, with Feed the Future and economic growth in communities. And my comment on the gender considerations is I agree entirely we need to focus on the women. But I wouldn't want us to have a focus only on the women because they often aren't the decision makers in the household. So yes, they will probably end up being the main caretakers of the children and health seekers for the family. But I, for example, would love to see the ag extension brought to the women in addition to the men, and for the men to get the nutrition education in addition to the women. So the decision making for both is better informed. Thank you very much.
Yeah. Our next speaker is Florence.
Okay. Good morning, everybody. I'm very glad to be here with you today. I'll try to speak about a concrete experience. I mean, how these linkages between nutrition, health, and agriculture takes place at the country level. And my example is Ethiopia, because I spent 3 years in Ethiopia and I arrived here in Washington only 6 months ago, so it's still fresh in my mind, and I was even in Ethiopia 2 weeks ago to work on a follow-up of what I was doing there during my stay. So I'll give you just a bit of context. I mean, Ethiopia, huge country, 80 million inhabitants, and the World Bank projection says in 27 years it will double. So 160 million. So it's a huge issue for the country. Agriculture is a key sector for the economy, like in many sub-Saharan countries. You know, it's 85% of the export earning. It's 85% of the population, the active population. It's 45% of the GDP. So it's a key sector for the economy. Agriculture is characterized by subsistence farming. You know, the size of a farm, the average size of the farm, I think 60% of the farms are under 1 hectare, below 1 hectare, and 40% are below half an hectare, which is not sustainable, you know, for a household. So small size subsistence farming, little fertilizers, you know, 36 kilogram, where here in the States is 250, 300 kilograms per hectare. It's 2% of certified seeds. So this is the agriculture. In nutrition, huge malnutrition rate. I mean, half of the population of the children under the age of 5 are undernourished. You have 27% of the women in the age of childbearing, which have suffered from energy deficit. So that's more or less the context. And a high level of micronutrients deficiency. Vitamin A, of course, iron, but also iodine. Sorry. So in total, in Ethiopia, you have every year between 7 and 8 million inhabitants chronically food insecure, and which the government addressed through a national program. So these people have between 3 and 6 months of a food gap, and the government provides a huge program, which is a cash or food transfer during these food gap period. But in addition, if there is a shock, you know, drought, flood, an economic shock like the food price increase in 2008, then you have between 3 and 5 million people in need of food aid. So it's between 9% of the population and 13% of the population, which is under this food deficiency. The good news is that the agricultural production increased. Ethiopia had a very good harvest in 2009 and 2010. If you look at the progression of this malnutrition rate, it is decreasing. I think in 2000 we had 51% of stunting rate. It's 47 today, and we had 47 in wasting. It's in underweight, sorry, and it's 38 in 2005. So in 5 years, we had a decrease in this malnutrition rate. So that's the good news. So what is in place to address these two issues, and how do they link these nutrition and agricultural issues? I'll speak from the local to the national level, because at the local level, I believe it's much easier than addressing these issues at the national level. So at the local level, you have quite a lot in Ethiopia about these integrated food and nutrition security projects. I know about an FAO one because I worked for FAO there. So, but you have these kind of projects which look at vulnerable communities, and I remember we had one in Tigray, in southern Tigray and northern Amara, where you work with the communities and you understand what are their problems and what are their needs. And the project was providing kind of grant or credit for them to buy what they needed and to develop activities. So we had, you know, micro development plans like gardening, like all these activities which tackle the diversity of the diet. We had something on cash crop to increase their income for them to buy more food and more. But we had also these nutrition prevention, you know, thing, education on breastfeeding, complementary vitamin A services. So, and when you look at this project, and when you look during 5 years, you see an improvement of the communities in terms of income and in terms of nutritional status. Then you have the kind of project, so which I call integrated project, which is easy for an NGO, you know, to come to look at the community where they want to work and figure out what to do. You have the other projects which are joint planning. So you have a team which is a nutritionist team and an agricultural team, but they have decided to plan together 2 different projects, but in order to look at these linkages. So one is looking, the nutrition part is looking at the causes and what they could do, like for example the extension health worker, you know, looking at the agricultural issue when you speak to the extension health extension workers, and vice versa, looking at the nutrition issues when you work with the agricultural extension services. So that's another possibility. The third possibility, which I've never seen myself, but I'm sure it exists, is you have agricultural project, but when you develop and you plan for your project, you look at nutrition and health issues as well to understand well how your community functions and what are the problems that they face. So whatever you choose, you know, is it an integrated project, it's a joint planned project, or it's a sectoral project looking at your linkages beyond your box, then the issue is coordination, as you mentioned, because in Ethiopia you have 300 food security partners. So huge amount, huge little pieces a bit everywhere. So then how do you ensure that you don't duplicate, that it's not counterproductive even, you know, in some areas? And then the second issue to me, which is very important, is the malnutrition and agricultural production are a national issue. It's a national issue. So how do you scale up this kind of small project and you address these issues at the national level for the entire country? And this is where it's quite difficult, and all our projects, you know, don't go towards addressing that issue. At the national level in Ethiopia, I was there to assist the government in finalizing its policy and investment framework for the agricultural sector. So it's a kind of plan which says for the Ministry of Agriculture, these are the areas where investment is needed most. The idea behind it is exactly what Teguest was mentioning, is to say to a donor that coming, look, it's not in my plan. No, please fund what is in my plan. What are my priorities of investments? And we had a discussion, so you have always the same thing. And we had a discussion about the linkages between nutrition and agriculture. And because donors said, you need to look at these linkages, it's important. And so the government said, yeah, it's important. Let's put a sentence in the document. And we put a sentence. We said that's very important to look at the linkages without any operationalization. Because for the Ministry of Agriculture, it's clear it's the Ministry of Health mandate. It's not their mandate. Then you have the Ministry of Health, which has a national nutrition strategy. It was the first strategy in Ethiopia. It was launched in 2008, so not very old. And when you look at this strategy of the Ministry of Health, it's very well written, looking at the linkages between all the sectors: water, sanitation, food security, agriculture. Then when you look at the content, the activities, it's mainly preventive actions, the one that Kathleen mentioned: complementary feeding, vitamin A, iron supplement, breastfeeding, promotion, education. And then there is an implementation arrangement which says the Ministry of Health needs to work with all the relevant line ministries and needs to lead a coordination body with the Ministry of Agriculture, with the Ministry of Water Resources. And so on the paper, perfect. 2009, I think Oxfam or Save UK, I don't remember, did an evaluation of the implementation of this strategy. And the weak point was this coordination body, which was not functioning. So you have, these two levels. And then in Ethiopia, you have a wonderful avenue, which is this food security program. It's a national government-led program funded by the donors, 2.5 billion over 5 years, to address these between 7 and 8 million chronically food insecure people per year. And this cash and food transfer program, that you give cash or food against public works, and for the people who cannot give any public works, it's free cash or food transfer. And when you look at this program, and you look at, there was an evaluation on the impact of this program on the number of meals of children per day and the number of calorie intake. In some places, not everywhere, but in some places there were good results. So the program showed an impact on these two issues. The thing is, it's a Ministry of Agriculture program which doesn't involve the Ministry of Health. So the wonderful linkages that this program could bring are not there. But there is a potential. And I think what is missing, and I would like to conclude with that, what is just missing in Ethiopia is a shared framework between these ministries to understand the linkages between them and to understand each one roles and responsibility, because the Ministry of Agriculture needs to understand its role and responsibility in a shared framework regarding its own mandate. It doesn't need to look at preventive nutrition, action. It just needs to look at the agricultural production and productivity increase, which will lead to a decrease in malnutrition rate. And we've been working a lot on this coordination. We try to avoid this distinguish between these issues. We bring coordination body. That's always what we try to do. We try to do donor coordination. We try to do line ministry coordination. And I'm not sure that the answer. I'm not saying that this is not the answer, but I'm not sure. Because coordination, you put a lot of money, a lot of effort for some time, not, And I believe a lot in this shared framework. We did it, FAO, UNICEF, I think, and WFP did it in Afghanistan. And it worked quite well. That's my final word.
Okay. I'm sure a number of us have answers to all those questions. Shared experiences in the field. The partnership has been doing these kinds of forums for the last 10 years or so. We've been in existence and really interested in how we make progress beyond the challenges that we find, whether it's in health or nutrition or agriculture. How can we make progress? How can we incubate some ideas or learn from elsewhere, learn from what's happening in Latin America or in South Asia, and then move Africa forward? That's all we do. Now, for those who would like to get copies of the PowerPoints, we have a standard operating procedure here. Whatever we present or people present in our forums, we share with everybody. And that's you. We'll be able to get those. We have some staff people here who will make sure you have all the PowerPoints. Somebody is taking some notes, so you'll get some brief summary notes after we cross-check them with the speakers, of course. We're going to open this up for Q&A. Our team from AMREF has to leave in about 15 minutes. So we'll be quick about this and always welcome you to participate in our forums. Those of you who are new to the partnership, we are basically a research-based advocacy organization. We work with many civil society, public and private institutions to bring African voice to those people behind there, and also to the U.S. administration, to just make sure that we are considering what's priority in Africa, what's possible, how can we build partnerships between U.S. and Africa to make good things happen. And so the floor is open. Just mention your name and your affiliation. Keep it short so we can get to as many people as possible. My friend.
Alan Drew, the World Food Program. I think one clear thing from all three presentations is, and I believe this for a long time, that no issue is more disadvantaged by the sectoral approach to development and food security than nutrition. It cuts across. And I think, Florence, you made a good point. I'd welcome thoughts from anybody. This emphasis on the coordination approach, perhaps we should look differently at it and look more at the evaluation or the strategic framework approach. I mean, coordinate, just sort of calling for coordination too often produces a sentence you talked about. I'd like, to the extent everyone has time, to sort of maybe spin out a little bit more. What are the alternatives to sort of the classic coordination model that could better enable us to get this nutrition as an orphan issue, because it's number one overall, but it's secondary in every single sector. It's secondary in health, it's secondary in agriculture, it's secondary in food aid, and only when you put them together does it become primary.
Okay, Kathleen.
I don't know if I have the absolute answer, but Africa is actually the place where a lot of innovative things are being tried. because it is, I think it's nice to talk to people about coordination, but if they're in a sector, they have their sector mandate. If it becomes a sector mandate to make that linkage, but where does that mandate come from? A donor can suggest it, but when that project is over, the mandate disappears. Now, what's been tried? It's been tried different ways. Is that in the government structure, if you put nutrition in the office of the president or the planning and finance, and you give it a role where, because it's not just agriculture and health, it's education, because you have school gardens and training and nutrition education in school. So there are many, if you give it a coordinator, if they're a doer, then they become in conflict with the implementers in the sectors. But if you give a coordinating role and really some authority to say, education, we really need it to be in your mandate to do this, health, please do this, agriculture, and someone's watching over and has the authority because they're in the planning or financing or the office of the president. And this is working well. Of course, if it's created and then the resources and the authority aren't there, you might as well forget it. But there are some very interesting options in many African countries. Everybody's trying it differently. Teguest.
Yeah. I think coordination is an issue for everything, and nutrition particularly, because nutrition always, in the health issue, it's the last thing. But when you go to Ministry of Agriculture, yeah, it is there, but that coordination between cross-section sectors doesn't work. But first, having coordination committees, wherever they are, in the president's office, and really it's not the solution. We have seen it with HIV. We said, oh, HIV has to be coordinated, it has to be placed under the Prime Minister or the President will chair it, and what. Do you think that the HIV activities were coordinated? Well, when we had all these national commissions under the president, it didn't work. It just created another confusion. So people need to be wanting to be coordinated first before you do coordination bodies. But the way to do it for me is really to have nutrition as a cross-section activity, and each ministry should be accountable to it. So it should be part of the activities, it should be part of what they're accounting for it, and that way it will work. Then it will have some budget line, and people will have some activity and will have. But I don't think whatever coordination, president office or any will solve them, or at the UN level. And second, it's when the donors are coming. One of the problems for coordination, it's at the donor level. Because each donor wants to have its own, program, project, and no want coordination. It is then for the national government to take the leadership, and that leadership capacity needs to be strengthened by organizations like FAO, WFP, and all other UN organizations. That's when we would really succeed.
Great. Florence, you want to say something?
Yeah, I just want to add one thing about, I think when I spoke about this shared framework in Afghanistan, I think it's exactly what Teguest is mentioning. It's understanding where it fits all these issues, nutrition, and how agriculture can address its part of nutrition issues. And then it becomes its mandate. But you need to have these shared understanding. And then yes, that's one. And the other is, it has been proposed I've heard sometimes, to put monitoring and to put indicators, because donors, we are also very much pushing for this accountability with indicators. And so I've heard, people saying, oh, Ministry of Agriculture should have indicators on malnutrition. Poor guys, I would say. Poor guys. I mean, how do you want to give the Ministry of Agriculture responsible for something which is largely beyond his control? So we need to be careful with the indicators as well, because we could say, oh, that's the way. We know.
Patrick Johnson from Brazil and Hamilton. Florence, you actually just touched on. It's it's really more of a comment than a question, I guess. I see a lot of parallels between this panel and then the recent work that Kurz been doing in the 2020 Initiative Conference that recently had in Delhi. And a lot of the talk around this is that it's really easy to conceptualize linkages between agriculture, health, food, nutrition, being a cross-cutting bar. Operationally, it's much more difficult. And so it seems right now there's a lot of focus, well-placed focus, and well-meaning focus, in identifying the metrics that can help connect these sectors. And I was wondering, really what your thoughts are in terms of the right level where these metrics originate from, be it, the research community, the government ministries, and how the metrics can then be tied into the accountability that you're discussing.
Let's take a few more and then we'll get back to the panel. Any other questions?
Il faut que ça vienne de la recherche internationale.
I think, given what Florence talked about, I like how you sort of separated the national and the local issues, and we're talking a lot about accountability within different ministries, but then how does that translate down at the local level? We see a lot of these community health workers or extension agents who are already overworked, and now they're supposed to have agriculture and vitamins and complementary feeding and breastfeeding, and I'm wondering if even if we get people coordinated at the national level, how is that going to translate down? We've done a lot of task shifting, and sometimes the people at the bottom are now carrying this huge burden, and they're operating outside of their areas of expertise. So how can we translate that down the line to the community?
One last one. Okay.
Oh my God.
Sorry. My name is Gabe Liza from the FAO. My question is for Dr. Guerma. African presidents are tough, but their wives are much tougher. How much do you get to work with them, especially on issues of nutrition? Is there a First Lady's initiative that we can use that as a mobilizing tool for the community?
Okay, back to the panel.
Shall I? So I'll reply to your question about who should do the framework. I mean, what we've seen so far is the framework is often developed by us.
Exactly.
Supporting the government, of course, but it comes from us. It doesn't. I believe it doesn't work. I believe our role is to strengthen the capacity of the research institutions in the country to work with the government to develop such a framework. A consultant coming in a country for 2 weeks, trying to understand the country and trying to develop a framework.
I'm a consultant, that's why.
I'm sorry, but I don't think it's the easiest way to achieve your objective. And from the national to local level, I know that in Ethiopia, if you have something at the national level, if the government is committed to do something at the national level, it will be implemented at the local level. So then the issue is all these project funded, but government activities, government-led activity by their own budget, if there is a pressure from the national level, say, to the Woreda level, which is a district level in Ethiopia, you have to do your integrated planning and to deliver that during the year, it works. The issue is, to me, the main issue today is the capacity, to strengthen the capacity of these different institutions.
Okay.
How do you work with the president's wives?
Okay. Before I go to the president's wife, let me just comment a little bit, and then Florence is very right. One of the problem we had in the past is, okay, we all, and I was also part of this as a WHO person, we just went with our framework, with our ways of doing things, and we said, okay, this is the way to do. Own it. But they cannot own something they haven't participated in, something they really don't know about. So the way to do things, I think, should change. The way we do things is really just the way we want now do it. You go to the communities and say, what are the things that they will need first? What are their needs? How we can just really catalyze and build the capacities of these communities to get the good thing out of it. Maybe our way, but with their ownership. That's, I think, very, very, very important. And on the operational thing, we need really to integrate in the community health workers, and you said it, and it's really, community health workers should have in their mandate nutrition issues. So they should also have some agriculture issues. So you see, it's not necessary to have 3-4 persons to go to the community. If we do it in an integrated way, they can bring this information back. But the problem is that each information has to be analyzed by the sector which has the mandate to do it. So if that coordination is done even at the operational level, then we can make something happen. Because even if the Ministry of Health and the Ministry of Agriculture are coordinated, you know, it doesn't mean anything for the operational level. It's one person anyway, which is doing, who is doing everything at that level. So that, we need to start at the bottom and go up. And it depends on the country. Of course, in Ethiopia, the government has all the rope. But there are countries where governments say anything, but you know, the people are the bottom thing. So it depends on the country. But I think we should have several scenarios. In some countries where government is very strong, where there is leadership, we can have it. And then in other countries, we can start at the operational later and have a bottom-up. Okay, on the president's wives, you know, we had HIV with the president's wives. Yes, advocacy is good at that level, but I feel that sometimes, you know, it doesn't work as we would like it. We do a big show, you know, they're all there, you pay them to come to New York or whatever. But I think the way to do it is really to have an evidence-based advocacy, starting with the Minister of Health level and do it at the technical level. But on the other side, we need to do some activism. You know, we don't have to, you know, to put cream on the president because by taking their wife somewhere or not. But the presidents are elected for the people, and the people should have take them accountable also in health or in agriculture and everything. So the way we think about presidents and others should change in Africa. You know, I know the reality is a bit different, but it's changing. The wind is blowing this way. So it will change. So we need to have activism in Africa. We need you and me and Jim and everybody with our support. We need to say, you have committed to this. What did you do? National you know, budget, for 15% of national budget. What have you done? You went and committed this in Abuja. What's happening? Then when it doesn't happen, follow up. And that's the way we will change things. We will never change things in Africa if we go always and, you know, try to go through the wives or through their, no. This is their duty, their role. They should be accountable to us. And then they should work for the people. And that's the way I see it. And, you know, I'm in Africa. I work in Africa, but I would say it there too.
I agree. Just capacity, and not what the one that's outsiders, but building on what's there. Nutrition capacity is really, really limited. And when you think it's difficult because it's a poor cousin in health and it's an almost non-existent until recently cousin in agriculture, to navigate that capacity is almost impossible. So I think that's why it sort of stayed as weak in the national systems and often in the international system. I'm actually less worried about the community health worker being asked to give another task, because if the instructions are very clear, they will probably be able to do it. They're always sorting through people's issues. What do they really need? Do they need to be referred? So putting, and probably many of the nutrition things like the breastfeeding promotion are already there in their set of things anyway. But how they get trained and how the whole system is arranged and whether there's a coordinating body, capacity and leadership. But the real ownership is, I think the way to go, not outside.
Great. I think with that we bring our conversation to an end, but you can share your business cards with the speaker so this conversation can continue. We'll pass out the materials to you, and as Partnership to cut hunger and poverty in Africa, we believe in partnership. So we believe that U.S. and African organizations can participate together, share experiences, and build the capacity that's needed on the ground to make things happen. Thank you very much for coming.
Yeah. Those of us who watch get started.